He is a training co-lead for RX for RJ, an international collaborative working to bring restorative justice practices to academic healthcare. Additionally, he teaches in the Rush Center for Innovative and Lifelong Learning. Dr. Bell is a clinical health psychologist and directs geriatric and rehabilitation psychology at Rush University Medical Center. Thank you, and we look forward to your presentation.
Thank you, and thank you for having me. Good to see you all nice and early on a Saturday morning, at least here in the Central Time Zone. If there's anybody on the West Coast, I'm deeply honored that you got out of bed in time for my presentation. But no, I'm really honored to be here and to share our experiences from Chicago with you. Really focused on the lessons learned from trying to launch and having some great successes and still some challenges to develop a really articulated educational framework for LGBTQ affirming training in our very large health system. So looking forward to sharing that with you. If technology will, there we go. All right. So no financial relationships to disclose. I have a couple of slide related disclosures later on. I borrowed a couple of slides from a colleague and want to give them credit. But here's what we're going to talk about. We're going to talk about this articulated model that we've been developing for delivering this kind of training. And yeah, I'm getting a lot of people that I'm admitting from the waiting room, so I apologize for being a bit distracted, but
I'll do that, Dr. Beal, don't worry about that.
Thank you. Great. So we're going to talk about this articulated model we've developed and how it came about and how we're launching it. Talk about the advantages and disadvantages we're finding of using a train the trainer model to drive local ownership of this training, and to talk about opportunities to incorporate some more experiential elements into the behavioral practice into our trainings, rather than leaving them the flat PowerPoint presentation that I am subjecting you all to this morning. So I want to tell you a little bit about Rush. We are a large not-for-profit health system that includes a large academic medical center, as well as a health sciences university with large medical and nursing colleges, as well as a number of allied health professions programs. We also have 2 community hospitals located in suburban Chicago and a large outpatient presence throughout the Chicago area. So sort of a homegrown large system in the Chicagoland area. We have over 12,000 employees, 70 residency and fellowship programs, and have been a healthcare quality index leader since 2009. We have consistently been a leader for the past 12 years, and we're the first hospital in the Midwest to get that designation and have kept that designation ever since 2009. And we also have a longstanding commitment to Chicago's West Side. We actually sit on Chicago's West Side in the medical district there and have a deep commitment to the communities that surround us there. So I won't talk through all of this timeline, but I just wanted to share. So again, Rush has a longstanding commitment to the LGBTQ community, going back actually into the 80s. And I won't go too far into that history, but longstanding commitment to LGBT healthcare that has matured and evolved over time. In 2009, again, we were in the inaugural Healthcare Equality Index. But then in the last 5 years, we've really moved into a space where, rather than simply affirming the LGBTQ community in an undifferentiated kind of way, we have really, the LGBTQ leaders at Rush have really driven the system to embrace LGBTQ affirming care as a mission critical part of how we operate. And that started, again, about 5 years ago when we were the first health system in Illinois to offer comprehensive affirming insurance coverage for employees and students. We developed an LGBTQ liaison role. We did begin to integrate, with lots of bumps in the road, SOGI data into our EPIC electronic medical record. And that is an ongoing process, as I imagine many of you have experienced, but have been working on that for more than 5 years now. In 2018, all 3 of our hospitals were awarded the Healthcare Quality Index leadership status. And then about 1.5 years, 2 years ago, we really began to fully operationalize this as a distinct arm of our operation. And that particular process culminated in January of 2020 with the launch of Affirm, our first, the first interdisciplinary LGBTQ center in Chicago. We did launch in January of 2020, probably not the best timing in retrospect, but nonetheless, we had a year of amazing growth in spite of all of the other things going on in the world. We're able to make a number of strides forward and to provide wraparound care to over 350 patients. And I'll come back to this, and trained over 1,800 people over the last year and a half in spite of everything else going on in the world. So not the best time to have launched our center, but have made it a success nonetheless. So I want to give credit for those last two slides in this one. They're from Dr. Ravi Iyengar, our medical director at Affirm. And you will notice, are graphically far superior to some of the slides later on that I am responsible for. So I want to give him credit for the great graphics work, and take credit for the more rudimentary graphics later in the presentation. So this is the structure at Affirm. It starts with patient navigation and care coordination. We have 2 patient care navigators that really do oversee that wraparound service. So Affirm is a virtual center, not a geographic center. So we don't have a single location. We are distributed throughout our main campus and to a certain extent throughout our system. We have patients getting primary care at both of our community hospitals that are nonetheless connected to our patient care navigators and being connected to specialty care on our main campus. And our navigators are also helping our patients navigate their lives and their psychosocial landscape outside of the system as well, around experiences of discrimination, socioeconomic concerns, physical safety for a lot of our patients. So they're deeply involved in, again, overseeing really the whole process of how our patients get care. And part of that is composing an individual care team for each of our patients. Obviously, each patient has different care needs. That may include any combination of these 4 particular specialties and other specialties as well, but in particular, primary care and behavioral health, affirming surgical care, and OB/GYN reproductive care are some of the key kinds of care that we are able to provide on our main campus. And again, our navigators help put that team together and make sure care is going well. And again, this is not geographically centralized. So our patients are encountering front desk staff and the like at multiple practices within our system. And sometimes things don't go quite as well as we would like. And our care navigators are able to follow up, and we're able to do retraining as needed when those problems do occur. Then there's, of course, an administrative arm that connects us across the system, but also across the community. Affirm is centered in our Department of Community Health and Equity Engagement, which means that we are firmly connected to, again, the neighborhoods that surround us, as well as our own community health clinics. So we're able to leverage a lot of our community ties to provide care more locally to our patients, and to go out into the communities where they are and provide some of the care, provide some of that care now virtually. As we've discovered in the last year, that's more workable than I at least had ever imagined. And then to be very deliberate about when we do need to bring patients onto our campus. And then there are educational, research, and training arms, which is what we're going to be talking about for the rest of the time here. But again, just sort of doing the scholarly work of being an academic health center, as well as this ongoing work of training our faculty and our employees, and the ever-evolving work of truly and deeply integrating SOGI data into our electronic medical record. And this is our whole team, which again is a very diversified team that includes our medical director, Dr. Ravi Iyengar, as well as our administrative director, Dr. Sally Lemke, and a whole cast of people with really wonderfully diverse set of specialties and skills that provide great care for our patients, and it's a great team to work with. Yeah, so historically, I have been doing the work of LGBTQ affirming training at Rush for about 9 going on 10 years now. And historically, for a long time, we were using relatively, I developed some of the training, so I'll own it, relatively flat training that was very focused on what I now call values and vocabulary. Very important work to be doing. Honestly, when I started doing that work 10 years ago, it felt a little like I was pushing the limits, that people weren't quite ready or needed to be pushed to be ready for that training. And we were really taking that training into lots of different spaces, and it wasn't terribly well articulated to the needs of the space. And the amount of time it took was sometimes not nearly enough, and sometimes felt like a lot to the people we were training. So we really, over the last 3 or 4 years, have been thinking about how to better articulate our training to meet the needs of the people we were training and the patients that they take care of. And that's really what the remainder of this presentation and the work in my role as education lead for a firm has come to be about, is this providing this framework and really building a workforce of trainers in our system who can do different components of this training and help us with quality control, retraining intervals, those kinds of things moving forward. So I am not going to read this very busy slide, but I just wanted you to see visually, this is what our overall framework does look like. So it starts at the top here with 2 tiers where it is relatively undifferentiated. So sort of the standards and expectations we have as a system for all of our employees. And then we begin to differentiate by role a little more as you go deeper into the training and look more at the behavioral piece of things. So we have now, and I'm going to give credit to Ketzel Feasley, who is our center coordinator, for coming up with this particular arm of the training. I'm calling it Tier 0. So again, for a long time, our ask when we wanted to go to a practice or wanted to go to a department and do training was for at least an hour and a half of time to provide our values and vocabulary training. And a lot of people very happily invited us in. But other people, not because they don't want to be affirming, but because time is so precious and because schedules are so daunting, the thought of a live hour and a half training with a large group of people just felt logistically impossible. We also increasingly have wanted to get into orientations across the system. Again, wanting a big chunk of time in orientation when there's so many things like fire safety and where do you get your badge and how did the paging system work and all of that, that also has to happen in an orientation. An hour and a half is a big ask. Ketzel thankfully came up with the idea, though, that yeah, that's the ideal. We're not going to get that all the time, but any touch is worth having. So Ketzel came up with this idea of just the brief moment, a single slide, 5 minutes in institutional orientations, practice level orientations, faculty meetings, sort of routine meetings that we can at least get our name out there and some very, very basic information about why this is a mission critical piece of our work, what our expectations are, sort of what the values are that underpin how we expect people to behave and treat everyone, particularly LGBTQ patients in this context. And to reference that there are a set of best practices that we have more information about. So sort of a teaser to hopefully get invited in to provide greater training. And this has been a huge foot in the door technique that, again, full credit to Ketzel for coming up with this idea. And it seems to be working really well, particularly on the institutional orientation front, where, again, it is very hard to get any time at all. So getting a single slide is a victory. And it does seem to make people curious. So they're asking for more once we provide this teaser. So this is a redo of our old values and vocabulary training. Our goal remains, we want to get this in front of everybody in our community at some point in some way, talk more deeply about what our values and vocabulary are, why this is important, why it's mission critical. In a lot of settings, we also reference the EMR functions, but not in every setting. And we provide a lot of time, and this is part of the reason that we ask for an hour and a half. Often there are a lot of questions. If this is the first LGBTQ affirming training folks have gotten, there are a lot of questions, and we want to provide a lot of time and space for those questions. And I think we do a really good job of making our training a safe space where people who ask questions that are maybe uninformed questions can ask them without feeling like they're going to be censored or judged. So as long as they're asking respectful questions, even if it comes from a place of not quite knowing how to ask that question, that's absolutely fine. And we're happy to answer it for them and also help them think of better ways to think about and ask those questions moving forward. And again, we want this as sort of a level setting across roles in the institution. And we're playing with the dissemination of this content. Historically, it was all live. We're playing with a blend of providing some pre-work. Historically, in my experience, online things were not especially well received. People were not terribly excited about it. I think the COVID environment and folks actually just getting better in creating online modules that are engaging and brief. We now are getting a demand from people, can you please give us something that we can kind of pre-read for the session so that the live session is very high yield and perhaps a bit shorter, but very high yield, so that people come in with a standard set. They already have the vocabulary in their back pocket, so we can start with values, or they already have the values and vocabulary, so we can start with some behavioral practice. And that's the direction we're moving with this level of training. And then there is practice level training focused on the behaviors that we're hoping people will engage in within the practice. So we're trying to build these as very sensitive to the workflow of given practices. There's some push and pull there. We can only tailor the training so much, but we do want to be sensitive to who sees the patient first, what information are they collecting, are they able to access the SOGI data that's already in the EMR? If not, why not? Those kinds of things. So there's some behind the scenes problem solving that goes into this kind of training before we get there, so that hopefully things are already sort of systemically optimized, and then we're really training people to engage in the behaviors we want them to engage in to take care of our patients. Again, as specific as possible to the practice, the specialty, or the site. And sometimes there is a cut through of all three of those aspects of it's a particular practice and a particular specialty that does things differently than this practice in that specialty does at a different site. So try to make it as specific as possible, as local as possible. What we do, whether it's a slideshow, whether it is all behavioral practice, whether there is pre-reading or not, varies across sites and what they're expecting and how much time they can give us and how much space they have. Also, whether we're in this kind of environment or whether we are able to go live and be with a large group, which increasingly is happening kind of sort of now. Yeah, so again, it's really for tier 2, we try to make it as tailored as possible while maintaining some degree of standardization and control over what it is that's being provided. And again, there's a differentiation between clinical staff and non-clinical staff, and really trying to look at what their tasks are and what information and practice they need to do them well in an affirming manner. So our goal in the long, or really in the middle term, is to have tiers 0 through 2 managed and maintained in collaboration with local champions. So as we go into practices and do this training, our hope is, and it's been met with a fair degree of success, is that one or more people will step forward and really be excited about this work, really want to help us tailor it for their location, and really to some degree own it. So we don't want to hand it off completely, but we definitely are looking for local collaborators in different practices. We want to empower them to feel like they can do many retrainings when they need to. They can kind of keep an eye on where people are with this, keep an eye on when new people are coming into their practice, and maybe we need to do a whole new training. And to really manage that tier 0, make sure it's in every orientation slide deck, and some of that tier 1 training. Again, because when there's local ownership, there's local credibility. It also expands our workforce without us needing to actually expand our workforce. So we're using people who are already in place in these practices to do a piece of this training. And likewise, we are using the tier 2 to recruit additional trainers for tier 0 and 1 across the system. So not only are we recruiting people who can be champions within their own practice, but people who are maybe willing to do some train the trainer work and help us disseminate the tier 0 and 1 trainings even further. We are still developing our train the trainer curriculum, trying to figure out exactly how that looks, trying to hope that we can get back into doing simulation live and work simulation into the train the trainer part of things. But that's part of our long-term vision as well. And then our tier 3 training is what we call specialty training. And really this right now, our long-term goal is to bring a lot of this internal, to really own a lot of this training. But this is really the clinical training or very advanced practice management training. And we're not internally providing a lot of this now. We're not going to tell people necessarily, we're not going to clinically retrain people to become affirming providers. If it's something they're invested in, we're encouraging them to work with their specialty organizations and work with the university to get the clinical medicine or clinical nursing training they need to provide affirming care. But we do want to know about that. We want to understand who the providers in our system are who are invested in and capable of providing different kinds of specialty care to our community. And we want to understand what their training is and exert a fair amount of quality control over what external training people are kind of counting as specialty training, but also looking forward to developing as much of this for ourselves as we can. So this is the way we're thinking about tiered training, is that this is the kind of training that would be CE qualified and specialty specific for clinicians. So this is not the general values and vocabulary training that people are going off and getting somewhere else. We do want to keep that internal. This is, again, clinical medicine, clinical nursing training that they need to provide care to LGBTQ patients. We are also, in parallel with this, looking at developing hands-on clinical experiences for our students. I am actually going to be the course director for a pilot LGBTQ affirming care elective. That's going to be a cross-specialty elective that we're going to offer in the fall, that's going to include family medicine, psychiatry, and endocrinology. So I'm looking forward to doing that. And wonderfully, our students have really been clamoring for that. Our students have been ready for and demanding that for probably a good 5 years. And we are finally in a space to finally begin offering it as an elective for our M4 students. Would love to see it be a required experience either in the M3 or M4 year in the long run. And then for people who are non-clinical, I certainly think there is specialty training to be found for practice management staff and the like. And my way of thinking, and institutionally, we're doing a lot of leadership training now. So the way I think about this kind of specialty is that it should go hand in hand with leadership development. So when someone wants to be a leader in our organization, they need to have some really specific skills around taking care of LGBTQ patients or managing a practice that is taking care of LGBTQ patients. Yeah, so just pairing that with other aspects of leadership development, which also makes it very appealing to staff. So it's a bit of a carrot for them as well. So some successes we've had so far. We have trained over 1,800 high-touch employees in the last year and a half. So we had historically done a lot of training without doing a terribly good job of keeping up with who we were training and how. But again, in the last year and a half, trained over 1,800. The trainings we've used have been evolving over that time. So there's a lot of these employees who are going to want to retrain relatively soon. But have really had great success in getting people into sessions to participate in either tier 1 or tier 2 training over the last year and a half. And have been really deliberate. Again, historically, we went wherever we were invited. Sometimes it was more interest than actual practice relevance that we were speaking to. But in the last year and a half, we've been really deliberate about thinking about all of the constituencies that might need this training. Our environmental services, food services workers, our anesthesiologists, our surgeons. So lots of constituencies that had not been high priority for us before we really began thinking about things through the lens of who is taking care of our patients, who is going to literally or figuratively lay hands on them, who is literally or figuratively going to have a conversation with them. Those are the people we want to train first. And that's what's led to this push to train the people we've trained over the last year and a half. Training has been really well received. We honestly had some concern that in some constituencies it would be less well received than others. It's been really well received. Questions have been respectful. At a lot of the early trainings, there were questions about whether people could opt out of taking care of trans patients, and people were not asking for themselves. They were imagining, they had some imagined coworker who would be uncomfortable providing this care. And it was really interesting to see that within each group, there was always someone, and often many people, who would step forward and say, no, that's not how we operate. We're not going to have people opt out of taking care of these patients. Maybe this isn't the place they should be working. So that's certainly that would certainly be what I would have our institutional position be. But our institution hasn't necessarily had to take that position, because there's a lot of sort of within the culture, that's kind of the pressure that, no, we're taking care of everybody. And if you're not ready to take care of everybody, this might not be the place for you. So it's been very nice to see how well received the training has been, and that stance has come really from frontline people taking care of our patients, and hasn't had to come from a leadership position. Again, what I just said, a high degree of investment and ownership by learners. A lot of local trainers have stepped forward. A lot of people, having a hard time thinking of a training where I didn't have a conversation with someone afterwards where they really wanted to get involved. They wanted to bring this to other people they worked with. They wanted to co-own this with us. We've been invited into a number of new areas. A big part of the motivation for having such an articulated system is that every time we would get together to have an education meeting, we would realize there was a different constituency, a new constituency that we had not thought of, that wanted our training or needed our training, or both. So we developed the articulated system, which again is helping us manage capacity, but we continue to be invited into new areas. There continue to be new constituencies who are interested in this work, who want to hear of it. And want to get involved. So even as we increase capacity by training people locally and using this articulated system, the capacity grows. We need more and more trainers. There have been a few areas of concern, just behaviors, not individual employees, not meeting our standards, not engaging in genuinely affirming care, particularly around patient communication, particularly around pronouns and name. And our presence as trainers, are having trained so many people in the system in so many different roles, has given us leverage to intervene when those concerns have come up. We've been able to elevate those concerns really pretty quickly and engage in a conversation about this being signal that we need to do more training, not a signal that we necessarily, although sometimes that too, it's not necessarily about disciplining an individual employee, it's about a training deficit, usually in an entire area. And this work has allowed us some of that leverage, and has allowed us to be in spaces where we can have hard conversations with HR and medical staff around the systemic changes that need to happen to be a genuinely affirming, to continue to grow as a genuinely affirming health system. Things we have not done yet that certainly are on our list is that we want to find a way to very effectively measure the behavioral impact of our training. We want to be able to demonstrate, because it's important to us and because it builds capacity, that we are changing the behavior of the people that we're training, and we want to measure that, and we want to measure it frequently because we know there is a retraining interval. We suspect that every 6 to 9 months, most people are going to need at least a refresher. They may not need the whole training again, but they're going to need a refresher or a reminder. These behaviors do fall off, like most behaviors do. So we want to identify what the right retraining interval is and hit that interval or hit just behind that interval so that people aren't engaging in less than ideal behaviors before we can retrain them, but also that we're not retraining them so often that it's inefficient. So looking to do some scholarly work around what our local retraining interval ought to be, and then of course retraining. And then if we go back to the big green slide that has everything on it, conceptually this framework includes both our students and our hospital side, our university and hospital side operations. I think conceptually that's great. I think in practice that can be somewhat problematic. There are different learning objectives on the university side than the hospital objective on the hospital side sometimes. I think there's a lot of room for synergy between the university and the hospital, but I think there's going to be some differentiation as well. And then likewise, the more we do this, the more we find out people are doing other kinds of trainings. People had training needs that were unidentified, unmet 5 and 6 years ago. So they did something for themselves at a particular practice, or particularly our community hospitals have been doing things on their own. They're both relatively new to our system, so they had their own things going. And we're continually finding out that there are many trainings going on or other efforts going on. And we want to capture that enthusiasm, but we also want to standardize the training. So we want to find out who's doing these trainings and bring them on board with our training so that we have some quality control, but we certainly don't want to tamp down their interest and enthusiasm. And again, in a large system, we're going to probably continue to uncover things for a little while, and really want to gently coordinate them so people feel empowered to pursue this as an interest, to train the group that they work with to the highest possible level, but also have some centralization and some central understanding of what it is that they're doing. Looking ahead, some of our aspirations are, and I really appreciated the presentation on simulation on Thursday, to fully integrate simulation into Tier 2 and Tier 3 training. We were just beginning to explore that, build a budget for that, and then COVID happened last year. So hoping that we can get back to doing live simulation and working that into some of our trainings, at least in the near future. Also hoping that as we build this, I mean, this is a big operation for our health system, which is a big operation of itself, and would love to become a training destination for a lot of our regional institutions, particularly our referring hospitals, local community hospitals. I think there's a lot of need there, and would love for us to be a training destination for those regional institutions. I also tell our students as we send them out on residency, or as we even send them out to community clinical electives, that they often are going to be the most expert in this work in that space, and that if it's really important to them, that it's great to come to an institution like Rush that has a center, but it's also incredibly powerful to be an informed, invested, LGBTQ affirming provider in a space where that's needed, where there aren't enough of those. And that's kind of my personal aspiration for our students, is that they become sort of missionaries for this work out in other spaces where it's not as quite as well developed. And we also are hoping to establish an LGBTQ plus fellowship, likely in our Department of Family Medicine, but ongoing discussions about where the best place for that would be. Yeah, so that's something that is one of our dreams. So to summarize really briefly, and I have not kept an eye on the time at all, so I have no idea where I am with time, but this stratification really can help override the logistical challenge of training in a large health system. It has the capacity to provide just enough training to meet the demand, or the imagined demand of a system, of a particular practice or area, rather than trying to provide the same, maybe too large, maybe too small training to everyone, which again is what we did for a long time and struggled. But the stratification is really our approach to making it work in such a large health system. Our training has generally been well received across settings and roles, and it has generated that local ownership, which is super exciting. It's always great to meet people that I don't already know in the system who are really excited about this, who want to get involved. It does increase the sustainability of this model. It's going to make standardization challenging, but I think that's a challenge well worth taking on. Yeah, and I'm happy with that to take questions.
Thank you so much for the presentation. So I think it would be easiest to actually start with the questions that are in the chat, and then we can go from there. So the first one I see here is from Brett Cooper. So the question is, Jake, can you talk about the decision to be spread out versus localized in one central space? Has this affected patient navigation to different specialties?
It probably, in that regard, COVID may have actually helped us in launching the center, because that was kind of going to be the patient, even if we had a physical center. A lot of the care we've been providing over the last year has been virtual. So I think I think the decentralization has been well tolerated by our patients because to a certain extent, it hasn't felt decentralized because it's all been on their device, or a lot of it's, not all of it, but much of it's been on their device anyway. A lot of follow-up care has. So the geographic challenges haven't been quite as impactful as I think they ultimately will be. I think it's going to be a challenge. We have a large campus. Chicago is a city that's built on a grid that makes it very easy to navigate. Our campus is not built on a grid. There is absolutely no logic to our campus, so it's physically challenging. So I think there will be a little bit of a challenge there, but again, our navigators are prepared for that, I think.
Okay, and the next question I see is from Ed Callahan. Can you describe how you get patients to share their sexual orientation and gender identity? What is the level of completion of these data in your EHR?
If you hadn't asked me, I probably could have told you. I don't know what our stats are. We transitioned it, again, in the middle of the pandemic, to our patient access center. So actually, as people come into the system, our patient access people are asking this as part of the intake. That is going well, and it's upped our completion rate. Again, I don't have the number in front of me. And our patients are tolerating it well. So I don't have the intake form open in front of me, but it is part of an intake. So it's asked along with address, insurance information. So it is really just normalized as part of our access center. I think our established patients are the patients for whom we have the probably poorest completion rate. So patients who've been in the system for a long time, who no one has ever asked them their SOGI information. I think we still have individual providers making assumptions that they know what a patient's SOGI information is, and are only asking when they are making the assumption that a patient is queer, non-binary, and aren't otherwise doing it. So that's an area, it's our established patient where we actually have more catching up to do.
Okay, great. So next question comes from Cami Bellis. What do your retraining intervals look like, meaning time frames?
So we are using a completely non-empirical, and that's why we would love to make it empirical, interval of 6 months right now. We're honestly having a hard time hitting that, but that's our conceptual goal, is to do at least a touch back every 6 months with people. We're actually hitting it with our certified medical assistants. We've gotten really great buy-in from our CMA program. We get them at orientation and we do a follow-up at 6 months. Yeah, but we're assuming 6 months is the correct interval, but we do want to measure that, because if it could be 9 months, if it could even be a year, then obviously that's more efficient.
Okay, great. And that sort of leads into the next question as well from Melissa Flores, when you were talking about measuring on the training. So she asked, could you speak more about how you evaluate your trainings?
So that is a work in progress as well. Right now, we're using a simple sort of did you understand the training kind of post-training checklist. But we're looking to develop, and if anyone, please contact me if you have great behavioral measures. We're at a place now where we're really looking to develop our own, because we haven't found great measures. Most of the measures we found have been measures of absence of homophobia and transphobia, as opposed to presence of affirming behaviors. So looking to develop that, or looking to identify that, and have not had the best luck with that. But that's our goal, is to have a measure that is genuinely behavioral.
Okay, and it looks like the last question I see here in the chat comes from Patrick Heron. Apologies if I mispronounced the last name. Can you expand on what the learning objectives or scenarios would be for simulations you were planning to implement?
So the scenario that we were working on when COVID hit was to do a full practice simulation. So to have non-binary simulated patients come in and to really set up our sim center as if it were a whole practice. So to set up a front desk, to set up, have a CMA go do an intake with the patient, have the physician or nurse practitioner provide the care to the patient, provide an after visit summary, and then the patient would go check out. So a walkthrough for really, our starting place was primary care. So kind of the undifferentiated patient going to a primary care provider for a well visit. So not even focusing on any particular complaint, not doing the sort of things that we do with our students where there's some super secret diagnosis to find out, but really looking at primary care provision at a cross practice level.
Okay. And I have, I don't see any additional questions in the chat. And as I ask my own question, if anyone has anything else they want to add, please feel free to add it in the chat. But mine is, can you just talk about any resistance you encountered in launching your trainings?
Yeah, I think the resistance that we continue to, again, I've been doing this training for a long time, and even back in grad school, I did this kind of training in the rural South a long time ago, not even this century. And I was, when I began doing this work again at Rush, I was really anticipating that kind of resistance where people would say deliberately hurtful, harmful things, and would be completely resistant to the idea of LGBTQ affirming care. We have encountered very little of that resistance, almost none of that resistance. The resistance is to giving people the time, or to giving us the time rather. So it's when we ask of busy departments that they stop things. We have a large offsite outpatient center in downtown Chicago, and we have asked, it's like, this is one of the primary locations where our trans patients go for gender affirming care. You know, we need to train the entire staff, top to bottom, everybody in the building we want to train. Can you close early one day so that we can do this? And the resistance has been just hard to overcome because it's time and it's money. And that, more than anything else, has been the challenge and resistance that we've met with.
Okay, understood. There's one more in the chat. Can you talk about the difference between training mental health versus medical health providers? And quickly, Nelson did make a note, if anyone wished, to ask a question verbally, just raise your hand in the Zoom as well.
So we haven't really differentiated our mental versus medical provider trainings. Our mental health care is really, I'm a clinical psychologist, really deeply embedded in our medical operations. So both geographically, but also by site of care. All of my patients are patients who are also seeing, and sometimes I'm seeing in the same clinic, our physicians. So it's really very embedded mental health care that we provide. And again, the specialty, the sort of practice level, how do I, as a clinical psychologist, provide psychotherapy to LGBTQ people, is not a level of training we are mostly providing in-house just yet. So we're hoping that our providers are, being mindful of their own scope of practice and competence and getting the training they need from practice organizations and programs like that, and then bringing it back to us. We do want to know what that is, and just be aware of what that training is, but much of that kind of specialty level training is still happening externally.
Okay. All right. I don't see any additional questions in the chat. Let me just make sure no one has their hand raised. Okay, I don't see that either. Okay, so I have one final question, and then I can hand it, I suppose, back over to Nelson before we close, but the final question I had is, how often are you requiring retraining? And apologies if you went over that specifically in the slide.
Yeah, so we're approaching it with the idea that 6 months is a good retraining interval, even if that retraining is a simple, brief refresher. But again, we haven't empirically shook that out yet. That may be too frequent for some settings and not frequent enough for others.
Yes.
So we're still figuring that out. But 6 months is sort of the intuitive goal right now, and we'll see where that works and where it doesn't.
Okay, great. Thank you for just reiterating that. Oh, another question came in from Patrice Ballard. Can you please expand on the 3 tier